This conference will now be recorded.
This was part of a lecture which was delivered at ASICON 2020, December. So we're talking about the choice of operations for inguinal hernia repair. So why is this question important? The question of which operation to choose for inguinal hernia repair. Now, the problem, if you look at the problem worldwide, there are more than 20 million patients undergo groin hernia repair annually. And because there are so many different approaches to this problem, the treatment indications, and a significant array of techniques for groin hernia repair. And today, I think there are almost more than 100 operations existing for this problem. And the goal has to be standardized care. You have to minimize the complications and you have to improve the patient outcomes, especially the decrease in the recurrence rates and reduce the chronic hernia, which are the two main outcomes that are always problematic. And these are the most frequent problems, right? Now, if you look at the determinants of choice, what are the choices that you have? So, the choosing an operation for inguinal hernia may not be easy because no one repair fits all. There's so many variations. And the reason is not very difficult to understand. Because despite those defined goals that we just now enumerated, the choice is no longer dependent solely or entirely on a surgeon's decision or skill. The other variables to be taken into account, the patient-related variables, the hernia-related variables, and on top of that, the recommendations which have come up lately by professionally qualified and acceptable institutions and societies. And on top of all this, there's still other lingering and unanswered questions. Now, one of the recommendations or the body which I recommended lately is the hernia search group. And this was initially there were recommendations being proffered from time to time by various laparoscopic societies. The EHS, the European Hernia Society, 2011, they updated it in 2014. The International Endoscopic Hernia Society, 2011, they updated it in 2015. So these are all new level 1 evidences, statements, conclusion, and recommendation. So there were various bodies. So all these bodies came together. And in 2018, January, there were 5 Continental Hernia Society, the European Hernia Society, the International Endoscopic Hernia Society. They came together and they formed a steering committee of 10 hernia surgeons, 40 other members, including anesthesiologists, pain expert. They had 3 external reviewers from 3 leading continents. And they went through almost 3,500 published articles. And they formulated guidelines according to the AGREE instruments. And this was after 5 meetings that they had. And they come up with 87 recommendations. And these were published in 31 chapters. So based on the literature evidence and the view of complete committee members, as expert opinions, they formed the hernia surgery recommendations of 2018-19. And it seems pragmatic to follow these recommendations. Now, starting with the patient concerns and queries and demands which have to be addressed. The important ones to be addressed, the question that the patient asks regularly to the surgeon, do I have more than one option? Which one should I go in for, laparoscopic or open surgery? Should I have a mesh implanted? What risks are shared with this type of surgery? Would I have infection? Would the mesh remain there lifelong? Or the mesh has to be removed later on? These are frequent questions. Can I have a hernia again? Very important for the patient. He's worried that I'm getting this operation done. So am I going to have the recurrence after this? And how long do I need to stay in the hospital? How long will I be off work? So these are important problems for the patient, important queries the patient puts forward to you. They are trivial ones, but then they are not a major concern. Now, the treatment principles are important. Why? Because a new recommended policy is gaining acceptance, especially in the earlier, this special group of early hernia patients, the asymptomatic patient, the direct inguinal hernia, the elderly patient, hesitant or reluctant patients, and severely comorbid patients. They form a separate group. And the problem comes in if there's some kind of surgical problem or do we really need surgery or not. But the mainstay of therapy still remains the surgical treatment. And the surgical treatment either going into the open route or a laparoendoscopic hernia. Yeah? So laparoscopic route or open route are the two options available. But strangely, the figures even today, only 20-30% of surgeons they attempt laparoscopic approach for hernia. The rest of them are still being carried out by the open approach. But fortunately, the numbers of surgeons doing laparoscopic intervention for hernia, they are increasing. Certain terms need definition, like for example, herniatomy. Dissection of the sac, we know that. Open to visualized contents, that is what otomy always means. Visualizing and closing and depositing back on the perineal space. But what is slightly strange is that excision of the sac is also included in the term herniatomy, while it should have been included in the term herniectomy, because excision anywhere, the suffix ectomy is to be applied. It's known as herniatomy still. So we'll follow that. Herniorrhaphy and hernioplasty, the definitions are important. Rhaphy always means approximation. And approximation of what? The edges of the defect in a tensionless manner. Hernioplasty, on the other hand, is bridging. Bridging of what? The defect margins. And that also, again, has to be tensionless. And what are we using for the bridging? Using the natural tissue available at the defect site, or the biological or synthetic material available to us. So it has to be tension-free. And then this inguinal hernia can be approached from the anterior part, or it can be approached posteriorly from behind the anterior wall. But this is not the only difference when you say anterior or posterior repairs. There's another definition to it. And the definition for anterior repairs usually encompasses that when you're using tissues which are lying anterior to the inguinal canal, anterior part of the inguinal canal, at any part of the inguinal canal, which basically means the external oblique, the internal oblique, which cross from anterior, from the lateral third into the medial third, is they form the floor of the inguinal canal. The anterior two-third or the anterior third in the lateral part, it forms the anterior part of the inguinal canal. And these fibers arch over the roof of the inguinal canal and they go posteriorly. So in the lateral third, the anterior, posterior third, they are the posterior two-third, it is in the medial two-third, they are posterior. So it's not truly a posterior layer. External oblique is always anterior. So if we're using any of these three layers, it will be known as an anterior repair of a inguinal hernia. And the herniorrhaphies which we commonly being done, Bassanis and shoulders, are anterior herniorrhaphies. While the gold standard, the Lakenstein's repair, is a anterior hernioplasty. Why? Because you're basically addressing, stretching the mesh toward the inguinal canal, to the inguinal ligament, and to the arching fibers of the internal oblique. So that is an anterior repair. If you look at the posterior repair, which can be done both as an open repair or a LHR, the laparoscopic hernia repair, it should be utilizing structures which are lying posterior to the cord at all points. And there's only one structure lying there, and that is the layer of transalis fascia. So we're doing a posterior herniorrhaphy by the open route. It is McVeigh-Cooper's ligament repair. Okay. If you're doing a posterior hernioplasty, it's a mesh repair. All prepetal repairs are posterior herniorrhaphies. Can be done as an open method, the Nihals, the Stopas, the TIPP, the Kugels, and so on and so forth. There's a whole list. Ugare's procedure. While the laparoscopic hernia repair, the TEP, the TAPP, the extended TEP, they are all basically posterior hernioplasties. A word about Stopas is that this formed probably the basis of all laparoscopic hernia repairs. The Stopa repair, or the giant prosthetic replacement of the visceral sac, that is GPRPS. So this is enumeration of what anterior and posterior repair is. If you look at the essentials of repair, the dissection has to be after thorough knowledge of the relevant anatomy. It has to be precise and delicate dissection, and there should be adequate exposure of the anatomical structures of the inguinal canal. This prevents what? Unnecessary complications and recurrences. The incision for the open repair is a standard incision which starts 2 centimeters medial to the anterior superior iliac spine, travels parallel to the groin crease about 2 to 3 centimeters above, and it stops 2 centimeters lateral to the pubic tubercle. So once you given the skin incision, you approach the superficial fascia or the Glaudet's fascia. That's how the superficial fascia overlying the external oblique is known as. So you cut in the Glaudet's fascia, and subsequently you have the external oblique in front of you. Now, what is important when you cut the external oblique is the lower flap or the lateral flap should be adequate enough. Adequate for what? So that when you do a herniorrhaphy and try to close the external oblique or the inguinal canal, there should be adequacy of flap. So the flap should be large enough for that. It should be wide enough for that. So ensure an adequate lateral flap. And when you're giving this flap and you're raising the flap, you always prevent injury to the ilioinguinal nerve, which is lying just underneath the lateral flap. And similarly, when you elevating the medial flap or the upper flap, always be careful of not injuring the iliohypogastric nerve. The sac needs complete dissection. And how do you ensure the sac has been completely dissected? Until you find the margins of the DIR. Is that enough? No, that's not enough. It has to be beyond that, and you have to incise the transalus fascia layer number 2 until you have the pouting pre-peritoneal fat. That means once you give that incision, you should find the pre-peritoneal fat coming out of the deep inguinal ring. Once you have that, you can be sure that yes, now I have a complete dissection of the neck of the sac. Once you've done that, you will be completely visualizing the margins of the DIR. Complete visualization of DIR margins would be ensured only after that stage. And once you've done that, the sac either can be deposited back or it can be partially excised. So especially in a large scrotal sac. So when you do a partial excision, the distal part is excised, the proximal part is ligated and pushed back in. Or you can do a ligation and complete excision. The complete excision, that means the distal part is removed. But whenever you're doing any ligation of the parietal peritoneum, which makes a sac, you will be having a post-operative pain. There's increase in post-operative pain. So what has been advised is that if possible, do not excise the sac. Then subsequent to that, once you've dealt with the sac as whatever ways you want to, then you should always be repairing the deep inguinal ring, especially in type 2, type 3, where you find that the deep inguinal ring is patchwork. And this repair should always go from medial to lateral. So if this is the inguinal canal on the right side, you have to go from medial to lateral. Why? So that you increase the obliquity of the inguinal contents. And increased obliquity is one of the most important features which are required to prevent recurrences. In a laparoscopic hernia repair, the defect has to be visualized, but that can only be done after you have completely pulled back the sac into the abdominal cavity, either fully or partially. If you're doing it partially, you have to ligate the proximal part and leave the distal part behind. So here also, if it's a very large sac, the dissection becomes difficult. Just do a partial excision, pull back the sac inside. And once you've done that, then you have to do a dissection in the pre-peritoneal space, which basically means layer number 3. So if you're doing the transalus fascia layer number 3 dissection, what is lying in front of you is the transalus fascia layer number 2. And then once you've done this complete dissection, retracted everything back, then in front of you lies the defect. So the choice, once you've done this, the choice is clearly and broadly limited to only 2 things. One, whether you should go in for open repair or laparoscopic repair. And number 2, whether if you're doing open repair, whether you should be using a mesh repair or you're doing a non-mesh repair. Now, as far as the decision between open and or the choice between open and laparoscopic hernia repair is concerned, the hernia surge group does not give an overall recommendation in favor of either. And the recommendation is that it has to be individualized based on the characteristics of the hernia, the presenting features of the hernia. That's good enough. As far as the open repair is concerned, there is strong recommendation. Strong basically means that you should do it in favor of the mesh repair. Why? Because the recurrence rates of mesh repair is far less than after the herniorrhaphies, like for example, shoulders and basilis. So this is basically a very small list of the types of operations which you can do. So if you're looking at an OHR, that is open hernia repair, you can be doing a non-mesh technique. If you're doing a non-mesh technique, you can have a shoulders repair or a basilis repair or one of its many variations. If you're doing a mesh technique, you have the gold standard, that's a Lakenstein's repair, or you can have a transinguinal pre-peritoneal and the other repairs which are probably done not very frequently, but still being done, plug and patch, bilayer, and variations. This red is what we are doing in the last 30 years now, the transinguinal pre-peritoneal mesh repair. Then you go in for the endoscopic techniques or the laparoscopic techniques and the 2 time-tested methods, the TEP and the TAPP. The new entrance to this field, the single incision, the robotic, and the extended view TEP. So recommended as far as laparoscopic repair is concerned, the completely reversed anatomy is being seen. So we have to be very well versed with this point of anatomy, this view of the anatomy of the abdominal wall. You're seeing it from inside now. So that is a must. Until you know the anatomy completely, you'll never be able to do a successful TAPP or TP operation, right? The options available, I said earlier, laparoscopic, the TP and TAPP are the two main options available. And the hernia search clearly indicates that among the two, both have comparable outcomes. That means you're doing a TEP or you're doing a TAPP, if the overall outcome is concerned, it is almost the same. One will be having less pain, the other will be having more pain, one will be easier, the other is difficult, so on and so forth. But if you look at the end point, both have comparable outcomes. And the end result would be what? The surgeon's skill, education, and experience. So the decision or the choice between TEP and TAPP should be solely dependent upon the surgeon's education, his skills, and experience. Whichever he finds or whichever he's comfortable with, he should be doing that procedure. As far as ETP is concerned, it's a new, unproven procedure comparatively with comparative efficacy as compared to the other two already existing, but there are no prospective data available, and so it's too early to comment on the feasibility or the rather not feasibility, but the part whether it should be done or not done as compared to TAPP and TEP. The efficacy is still not determined. The guidelines, if you look at the guidelines, which are hernia specific guidelines, clearly says that a surgeon, a hernia surgeon, should be a surgeon who can be doing both an anterior and a posterior approach. So, surgeons should provide both. He should be able to do anterior and posterior options for tailoring the treatment. He should be well versed in that only. Then he can be called a hernia surgeon. Now, those presentations where a laparoscopic hernia repair is advisable is clear cut. Number one, primary unilateral inguinal hernia in men. Why? Because probably the laparoscopic approach gives less early pain and chronic pain in these patients. Bilateral inguinal hernia was always believed to be the domain or the forte of laparoscopic hernia repair. Female inguinal hernias, the sportsman's hernias, and of course femoral hernias, they all should be preferably be dealt with a laparoscopic hernia repair. Now, if you look at the individualization, the other group is where you have an individualization and you have a choice between OHR and LHR. So, recurrent inguinal hernias, it depends on the index operation. So, if it has been an index operation, has been open hernia repair, and then recurrence has occurred, then preferably you should go for a LHR approach. If it has been an index operation, had been laparoscopic, and there has been recurrence after laparoscopic, logically it should be an open repair, but then there are surgeons who would still like to go in for a repeat laparoscopic hernia repair. So that depends on the surgeon and on the patient's. So there you have to do an individualization in a patient who has a recurrence after a laparoscopic hernia repair or after an open hernia repair. Even an open hernia repair, you can go in for a second open hernia repair after recurrence. If it's a large scrotal and irreducible hernia, the Lachenstein technique presumably offers advantages, but hernia surgery group recommends that you should again go for individualization by the surgeon, so he or the patient can demand an open or a TAPP operation even in this group of patients. If there has been previous pelvic or lower abdominal operation, it's logical to say that it should be an open mesh technique because you would be suspecting there would be a lot of adhesions and the laparoscopic approach may probably not be possible. In a comorbid patient, severe cardiac or pulmonary comorbidities, high risk for general anesthesia, these are patients will probably not be able to do a TAPP or a TEP, so it would preferably be done with a Lachenstein's repair under local or spinal anesthesia would be having advantages. But there's a big but to it, and that is if you're able to do a laparoscopic repair in under spinal anesthesia or regional anesthesia, you can also go ahead with it. But then the time factor may also be important, and that's why a Lachenstein's repair under local or spinal anesthesia should have be having its own advantages. Then a third thing creeps in, and this group of patients where you can have an OHR or LHR or a combination. That is the hybrid technique. Like for example, irreducible hernia as a result of omentosis. You're not able to push the drag the omentum back behind. What you can do is you can open the sac in the scrotum, and you can either excise the excess part of the omentum, or you can push it back manually, close the sac, and then continue as a laparoscopic procedure. So irreducible hernias could be a combination of both open and laparoscopic approach for that patient or a hybrid approach. Then comes the group of patients who presents in an emergency. So you can have an emergency setting in the form of obstructed hernia or a strangulated hernia. As far as the obstructed hernia is concerned, if there has been no contamination of the operative field, uh, a laparoscopic approach can be tried and is feasible. If there is been collection in the sac, you can suction it off. But a Lachenzi's repair can be performed after laparoscopic repositioning of the incarcerated organ. So again, this is a choice between either OHR or LHR or again a hybrid approach. In strangulated, where there has been a bowel gangrene, there it is very clear that you should go in for opening the sac, deal with it as an open hernia repair. If you want to do anastomosis, do it, and then push everything back. And then there are three options. Either you leave it as such, that means you close the sac and leave the patient with the hernia for another day, then you can do it as an interval repair of the hernia. That's number one. Number two could be that after you've dealt with the intestines, you can repair the hernia without a mesh. And that is basically, it means a herniorrhaphy. A Schultes technique would suffice in these patients. Or the third could be they can also go in for a mesh repair or take like a seeds repair, but here do not use the synthetic meshes, use the biosynthetic or biological meshes because there is contamination and the chance of having increased infection with a synthetic mesh would be much higher. As far as the occult hernia is concerned, on the opposite side, suspecting it preoperatively, you already had talked it over with the patient, and relatives of the patient, and you find it during surgery, go ahead and repair it. And it would be better tackled if you're suspecting occult hernia, this patient should be better tackled by a TEPP repair, and there it becomes easy because it's in front of you whether the patient has hernia or not, and you can deal with it accordingly. What about the prophylactic hernia? This had been a topic of great discussion in all the forums, and there were a number of surgeons in view of in favor of doing a prophylactic on the opposite side. There were others who didn't want to do it, but now scientific evidence is there. After a review of almost 10,000 patients, they said that there's a highly significant difference to the disadvantage of bilateral results. That basically means that you should not go in for a bilateral prophylactic repair. So prophylactic operation of the healthy other groin should not be performed. A few words about the meshes. Again, the mesh-based repair, we said that it should be the preferred method. If you want to do a no mesh repair, that only should be if the patient is refusing or there is a shared agreement between you and the patient that no, he would not have a mesh repair. Now, despite comparable results, three-dimensional implants, like for example, the layered, the plug and patch, or the plug repair should not be recommended. Why? Because you're implanting excessive amount of foreign material inside the body. And that's why until lately, the plug and patch and the plug repair and the bilayer implants were very favored. They should no longer be done so, and you should stop using these, right? The use of other implants when you're trying to, which are going to replace the flat mesh and Lachenzi's repair is again not recommended. Now, what about the pain? When you're considering the post-operative pain, intensity of pain, probably a low weight mesh would be giving less amount of pain. That has been documented, right? But then this is a short-term benefit. It's not a long-term benefit. And especially if the patient has a direct hernia and a large direct hernia, like for example, M2 or M3, there are chances of having increased recurrences with the low weight mesh. And that is why there the medium weight mesh is recommended. About the meshes, the type, so we have the medium weight mesh overall that preferred because it gives midway pain, it leads to less recurrences. So medium weight mesh are to be preferred today. More so because there is a pore size of medium to large pore size, 1 to 1.5 millimeter, which favors less of fibrosis and less of plate formation. Medium weight, monofilament synthetic flat meshes, and the burst strength and the tensile strength should be in the region of 16 newtons per meter square, right? The fixation again is a question and whether you should fix it or not. Now, the TEP repair, it is left to the surgeon. If you want to fix it, do it. If you don't want to fix it, don't do it. That is option and that is the recommendation. But if you're doing a TAPP, the mesh has to be fixed either with help of tackers or with the help of intracorporeal suture. So in a TAPP, fix it. TEP, you may or may not like to fix it. Now, just a few steps of a Schultes repair, because this has been advised as the best opportunity of the best radiography. Now, if you look at the first one, after the sac dissection and management, the transhallis fascia is being split. So here you've got the internal oblique and you've got the shelving border of the inguinal ligament. This is the the external oblique, the flap which has been raised. So this is the lateral external oblique flap which is reflected back, and this is the external oblique medial flap. And here you got the iliohypogastric nerve in front of you, the oblique, and you bared the transverse fascia. So cut it from lateral to medial. That is the layer number one. Once you cut this, so once you cut this flap, you have in front of you the Bogorov space. This is the Bogorov space, and you have the veins in the Bogorov space. You got the inferior epigastric vessels out here, and laterally you got the cord structures coming out. So this is the lateral to the inferior epigastric vein. So inferior epigastric vessels. So here is the Bogorov space. Now it also defines something else. The way you reflect the lower flap or the lateral flap, and you go deeper down, you'll see the shelf of the inguinal ligament. Go deeper down, you'll be able to see the Cooper's ligament out here, which is the iliopectineal ligament. Now, the part between the Cooper's ligament and the inguinal ligament, deep down out here, is the area of the femoral ring. So you can easily see the femoral ring there. You can find any structure entering the femoral ring in this particular area. Here, superiorly, you'll find the edges of the internal oblique, you'll find the edges of the stars abdominis, and medially you'll find the edge of the rectus abdominis muscle. Now, I'm sorry. Now, you come to the third layer. Now, so you separate the layer number two. I'm sorry, it is stuck. Just take a minute.
This conference will now be recorded.
So now this brings us to the, I mean, it comes to the first suture line. You're taking the lateral flap or the lower edge of the external oblique aponeurosis, and here you got the medial flap or the external oblique aponeurosis. Sorry, the transalis fascia and transalis fascia. So now what is done is the transalis fascia lateral flap is taken under the superior flap or the medial flap and is stacked onto the flap with the help of suture over the tubercle, around the tubercle, and the facial structures. So that is layer number one, and is carried laterally. In the first suture line. Now this brings us to second suture line. Continuing with the suture line, you go medially, and in the medialmost part, the lateralmost part, you're including the cremasteric, the stump of the cremasteric muscle. So when you're doing that, you're narrowing the deep inguinal ring. So here the deep inguinal ring has been narrowed in the shoulders repair with the help of the cut cremasteric muscle, so the stump of the cremasteric muscle. So that is going to narrow the deep inguinal ring, and that finishes your first layer. So from here, it is again taken back and brought medially. The second suture line, so you close the first suture line and now traveling more medially. And when traveling medially, again including transalis fascia. Now this is much nearer to the inguinal ligaments. That's the inguinal ligament, shelving border. So you are including a part of the inguinal ligament along with the fibers of transalis fascia. You can see them here, and you are taking the upper level of the transalis fascia. So when you're doing this, you are bringing along to the second layer, that is the medial flap double-breasted. So medial flap is double-breasted over the lateral flap. So it's the lateral flap of the transalis fascia, the medial flap of the transalus fascia, and here you find the internal oblique muscle. Third suture line again goes from the medial part to the lateral part. So here now what you're including is again the under surface of the external oblique, and it is going to include the superficial surface of the internal oblique and the external oblique. But here see, the part of the flap is left. The part of the flap is left. So you have to have an adequate flap, as I said earlier. So you're tying it along to the surface of the similarly, the fourth layer, again, similarly, going from medial to lateral, and this is going to convert into the, the third layer was brought from lateral to medial, and now the fourth layer is being taken from medial to lateral to finish at the deep inguinal ring. So that is the fourth layer, and again, you should have an adequate flap remaining behind. So once you've given the stitches, an adequate flap should be there so that the final closure of the inguinal canal can be done. And this is again the part of the flap of the external oblique now being tacked onto the internal oblique muscle. And this, subsequent to this, now you're going to close the external oblique with the help of the now, certain things to remember that this was classically done with a continuous suture of 32-34 gauge stainless steel wire, and they're still being followed in Shoulder's clinic. But now mostly it's been done with synthetic monofilaments or polypropylene. Small bites have been suggested to reduce the tension of the suture line. An additional change in all inguinal herniorrhaphy, not only for shoulders, remember, even for bassinet. Initially, they used to transect the cremasteric muscle. It's no longer so. The cremasteric is no longer transected to prevent the ptosis of the testis. But otherwise, it was seen that subsequent to cremasteric excision, the testis on that side would used to hang lower down. Now, present day status, hernia search 2018-19 also strongly favors a shoulder repair. But there's a problem. The technique is difficult to learn and master, even at the Shoulder's clinic. They say that the surgeon should be doing at least 300 cases before he becomes proficient in the shoulder repair. And you can't have that amount of bulk of material in a routine hospital on a routine hernia clinic. 300 cases is a very sizable number of patients. So that is why, comparatively, even today, the bassinets and modified bassinets perhaps still the most commonly carried out repair, especially in low resource countries. That is about the shoulder repair, which is commonly should be done in the herniorrhaphy in all those patients who is being advised. Just a few words about another procedure which we have been doing in the last 30 years. And that is the TIP or anterior preparietal mesh repair. Now, this is a repair which is done through just a minute. Right. So this is a repair which is done usually like the routine repair. You dissect out the sac. Until that stage, it is entirely like any other dissection of the inguinal region. So once you've dissected the sac and pushed it back in, now comes the difference. And instead of just applying a mesh over the top of the posterior wall of the inguinal canal, now that is against the Pascal's law. That's against Pascal's law because a mesh applied over the posterior wall of the inguinal canal is against the Pascal's law. A mesh, if it was applied inside, just like in PEP, a TAPP, or a mesh applied in the preparietal space, would be following a Pascal's law. So that's what we do. We dissect out this particular sac, push it back in, and then we apply a retractor with the DIR, and we elevate the DIR. Now, when we retract the DIR, we can go into the level 2 and level 3, in between 2 and 3. Why? Because DIR, when you retract the DIR, you're retracting the inferior epigastric vessels along with that. Now, inferior epigastric vessels basically lying in between layer 1 and layer 2. So if you're elevating the inferior epigastric vessels, straight away you're entering into the layer of layer 2 and layer 3. And you can easily dissect out. The finger can dissect from here to the pubic symphysis here. It can dissect from here about 2 to 3 centimeters here. It can dissect here, go into the inguinal ligament area, go beneath the inguinal ligament into the ilopectineal line, and go further down. And Here laterally, it can also go 3-4 centimeters. Now, once it has done that, then the mesh can be pushed in. How we do it, you can see in one of the YouTube, the picture that we put in for the procedure of what is known as modified APP. But here suffice to say that once you push the mesh inside and you just leave the DIR, you see the whole of the posterior ligament is lying out here. So that is lying out here and the mesh is seen out here. So you don't need to apply any sutures out here. No need of sutures out here. The mesh is cushioning this whole thing. And the mesh is also following the Pascal's law. So you just need to narrow the DIR. And when you do it, as I said earlier, from medial, medial to lateral. So when you're doing it, you're pushing the cord more laterally. So you're creating obliquity of this canal. Okay, so that's what's done. You can see it in the next. See now here the Prolene suture have been applied, and these have narrowed the DIR. So once when you leave this, you have the whole thing repaired without any suture, especially narrowing the DIR. And this is the flap of the internal oblique, and here you see the iliohypogastric nerve. So this was the anterior preparatal mesh that we do for the last 30 years. You'll be finding this in the YouTube, my YouTube site. And then of course, the Lachenstein's repair for right direct inguinal hernia. I'm not going to go on the discussion at this point of time, the very commonly done procedure. But if you still want to see it, you can see this again on my YouTube channel, and you can see the whole Lachenstein's repair for right direct inguinal hernia. Thank you for your time.